who tuned in. We will keep this pretty informal and on the shorter side, but I think it's very exciting for not just students, but also like us to be able to all see each other's faces, because it's not often we get an interdisciplinary group of folks together. So that is exciting in and of itself. And so what we're gonna do today is I'll sort of just go through and call on everyone in our lovely panel and address a few very broad general questions so everyone can get an idea of who you are and which program you hail from if they have questions. And if you want to, if you're on the panel, it's very clear who we are because only our videos are on, which is cool. The students we work with hate turning their videos on, so it's okay. But you can put in your like name, like which program you are, just so someone could chat you if they have a question, just because it's going to be confusing because it's all letters soup. So we will go ahead and get started. I'm just going to move in the order of my screen. And the first question is, what is your name? And your, oh yes, if you're from Georgia Tech, you do that thing. And your preferred pronouns, and then what program you are in, and why you decided to do that specific program. And I'll give you the hook if you're going on for like minutes and minutes here, because I know there's lots of reasons. But so we'll go ahead and start with Catherine. So you're next to me on screen.
Hi everyone, my name's Catherine. I'm a Emory PA in my second year. My pronouns are she, her. I wanted to do PA because I wanted to get into the medical field. I had already been doing 10 years of work as a humanitarian aid first responder on the US-Mexico border. So I had some kind of hands-on patient care experience, but not a lot of the more like hard medical skills, I guess. And then also in a practical sense, I'm 38 and I didn't want to be in school for 6 to 8 to 10 years or so. So PA was kind of the sweet spot for me there. And I'm happy to answer any questions about what a PA does or what that training looks like. Did I cover everything? Let me see. Yep.
I think okay. You did. We'll do a few rounds, so don't worry. I'll come back for you. All right, Raven, you're next up on my screen.
Hello, everyone. My name is Raven Goff. My pronouns are she, her, and I'm in the MD PhD program at Emory. I would say what made me decide to do this program is indecision. I loved research and I loved medicine. And they're like, oh, well, you can do both. You'll be in school for a while, but you can do both. So that's why I ended up here. So if you find yourself liking medicine, but also liking research, definitely look into it.
Cool. And she's our lone PhD tonight. So she can also speak to she can pretend she's a pure PhD student if you have questions about that, because she's killing it in her PhD. So she can help you there. And I think you're at an Emory lab for your PhD, correct? Okay.
Yes.
Okay. All right. And then next is, so we'll do, all right. So Nathaniel and Lena are both from our YPI program. Nathaniel is going to speak to being an EMT because he was an EMT before he came to med school. And then Lena can speak to Nathaniel, if you want to throw in anything there for med school, you can. And then Lena can speak more to just the med school side of things. That sounds good. So go for it, Nathaniel.
So yes, I'm Nathaniel. I'm a first year med student, but I was an EMT before coming to college. I was trained as an EMT and then as advanced EMT. And talk about that, there's like 3 kind of core levels to EMS. So AEMT is kind of a middle level, with the paramedic being the next level. I wanted to do that. I wanted some hands-on skills. I wanted some exposure in the ER. I thought it was cool to ride out in an ambulance. So I had the opportunity, so I decided to take it. And I love doing it. I miss it sometimes.
Cool.
Hi everyone, I'm Lena. My pronouns are she, her, and I'm going to be a 3rd year medical student in a few weeks. But I'm in the MD program, like Harrison mentioned, And I guess I chose to join just the MD program because I kind of hate research, but I think the human body is really cool. So I like the clinical aspect of it and like constantly learning and just growing in your field and being able to work with people. So that's kind of why I decided to go to medical school.
All right, and moving down to Lauren.
Hey everyone, I'm Lauren. I'm a nurse in the Master's of Nursing program, and my pronouns are she, her. Let's see. So I'm in the AMSN program at Emory. So I got my bachelor's of nursing in August, accelerated. So only 4 semesters. So I graduated and then I passed my test, and now I'm in the MSN portion to become a family nurse practitioner. And I'm in my 2nd semester of that. And I just came from clinical, but then the master's portion will be until December. So in 8 semesters, I went from not being a nurse at all to, and then I'll be a family nurse practitioner, which is confusing. If you have questions, let me know later. It's a lot of explanation. So, and I joined it. I was a PCT in the hospital for 3 years, and I didn't know I wanted to be a PA or an MD or an NP. I wasn't sure which. And I really liked the nursing approach to things. I have great respect for PAs and MDs, all the people on this chat, but I decided that I wanted to be a nurse. So that's why I pursued that avenue.
Beautiful. All right, and Stefano, first tell me if I'm saying that correct, and then you're good to go.
Yes, my name is Stefano. I'm in the DPT program, which is the Doctor of Physical Therapy. My pronouns are he, him, and I got into physical therapy, I guess formally, maybe like in the middle of undergrad, because I came across it through an association. I didn't really know too much about what physical therapy was until then, but I knew from when I was maybe like a teenager. I was a swimmer growing up, and just having a lot of my friends get injured and like me getting my own injuries, and just the frustration of like not really knowing what's going on, and kind of the fact that most people don't really get it addressed proactively, and me really want to pursue some way in which I could help others just prevent those injuries, recover from those injuries, understand them a little better, because it sucks not really understanding what's going on with your body. And I felt particularly drawn towards PT because it seemed like a health profession where you could spend more time one-on-one with a person. That really appealed to me. And also the hands-on part where depending on what setting you end up working in, there's a very big hands-on component, and I really enjoy that part as well. And just as I did more, got more experience kind of getting my hours of volunteering and working in different environments, it's really cool seeing how like the world of PT is much bigger than I thought it was. A lot of people, when they think of PT, it's just outpatient ortho. So it's just like all the musculoskeletal stuff you would think of. But there's really so much more. So it's really cool that like once I graduate, I have this kind of like general and pretty in-depth understanding of different things. And throughout my profession, I can kind of choose to work in different settings. And I really love the interdisciplinary component where like I had some experience in a hospital, and it's just so cool to work with nurses, PCTs, MDs, speech therapists, OT. It's just really, really, that's one of my favorite parts. So.
Awesome, thank you. So we're gonna do another quick rapid fire round, but just we are in putting together this panel. I could not represent everyone in the hospital, so Stefano already hinted at one OTs, who I almost had an OT comes in. I was like, this is too much. Also medical assistants, or I'm gonna miss many people there in the hospitals. There's also imaging techs. There's also techs of all sorts. There's phlebotomists who draw the blood. So there's a lot of people who keep hospitals running. So if you want to work in that, and Lauren, what were you gonna say?
And in COVID times, respiratory therapy, they're saving us all.
Yeah, that's a great addition, for sure. And then there's like many levels of nurse, which we will not go into today, but Lauren could perhaps answer any questions about that, because it is, even I have to like remind myself the acronyms. But the moral of the story is all of these professions work together, and they have different nuances in how much time you spend with patients, what your specific role is, but they can all be incredibly impactful depending on how you use it. Like any skill or anything. So the next rapid fire round, we can go in the same order. I'll type it in the chat so we can look at it so I don't have to keep calling. But just quickly say what is entailed within your program. So years, just rough outline of what it looks like. And then if there's anything specific that you need, if you're considering applying, and I think this is more for the nursing and PA and perhaps PT folks, where hours are involved, and you need specific experiences and some random classes sometimes. We won't go into classes too much because everyone here, is in some sort of collegiate or high school atmosphere where they have guidance counselors and can help them with that. But sort of broad strokes of your program and anything's going into it that you really have to know if you want to be a PA, for example. Like, what do you have to know to do? If that makes sense. So, Catherine, take us away, and I'll type the order in the chat.
Sure. So PA programs vary in length. Emory's 28 months with no breaks. So just straight through. Usually they're 2 to 3 years. They also vary. You have to have some hands-on patient care experience where you're like directly working with patients. At Emory, I think it's a minimum of 3,000 hours, which is usually working for a year or two, although most people have more. And then it can be at different levels of kind of involvement. So we have a lot of like EMS, we have some paramedics, we have some RTs, MAs, all kinds of people who've worked in different roles, which is one of the cool things about PA. You get to kind of learn from all your classmates because all of them have their thing that they did before PA school. So we had someone who did like echoes and she knows everything about the heart. Yeah, prereqs a little bit less than med school, but kind of the usual science. I had to go back for all that because I was an English major, but that's another story. And I think that's, and then whatever, applications, essays, references, all that stuff.
Cool. So for MD, PhD, and PhD programs, because you're asking or showing them that you want to advance your career in research, they usually want at least about a year and a half plus worth of research experience. The MD, PhD program could last anywhere from 7 to 10 years. The MD is a standard 4 unless you add on an additional degree, but it's really how long the PhD takes. And sometimes that's in your hands and sometimes it's not. Research is different. You can do research in biomedical science. We have people who do research in biomedical engineering. We have people who do research in sociology and psychology. There are even some programs that you can do PhDs in art history. So it's not just wet lab or basic science research like basic biology. You can pretty much do research in almost any field depending on the program. And the programs, some people have finished in shorter times, like 6 years, maybe 5, if they come in with backgrounds, heavy research backgrounds in the area that they want their PhD in. But the standard time for completion is about 8 years. Most programs range about 8.2 years for you to be done with your program.
I think yours is unique in that cost is a unique aspect of an MD, PhD.
Oh yeah, definitely. I thought this was going to come in the advantages and disadvantages section. So most PhD programs are fully funded. So you will they pay for the PhD degree and you also get a stipend. It's a living stipend. You can live off of it, usually, especially in cities where the cost of living is lower. MD, PhD programs are fully funded, so they pay for the PhD and the MD, and that's a great incentive because you also on the back end would lose out on 3 to 6 years of earnings as a potential doctor. So they try to incentivize you on the front end. But it's definitely a good option and you don't necessarily have to look at the time too much in terms of lost wages because you kind of make it back on the front end.
In terms of ENT training, so it depends on the level that you do. So if you start out just as an ENT, that might take 6 months of training, but most people are going to maybe do AMT or move up towards becoming a paramedic. That might take 2 years. And that could either be like a certificate or just licensure, or you can get like associate's degree, depending on where you do your training. In terms of training, what's involved, it's going to be heavy on skills and heavy on like getting a familiarity with how to take a history, how to do it quickly, how to make a decision on transport, not transport, where to transport to. If you need any additional assistance, you need to like call in a helicopter, you need to call a higher level of training and stuff like that. So working through all those kind of decisions, and then how to work like in different situations, like because there's a lot of scenario training involved in terms of you're going to walk into a situation and not know from the beginning like what's going on. So if you walk in the door, it may not be what you thought it was supposed to be, or it may be a lot more involved. So they try to prepare you for things like that. And all that's going to go down in that, you know, if you become an EMT, like I did, that took about a year. And that's including hospital rotations in the ER, ambulance rotations, and then afterwards, there's also some continuing education. And that's not going to be paid for, or usually it's not also like financial aid, so you're paying out of pocket. But because it's sort of you can usually start working like very soon after, if some people are also working that throughout the entire period as well. So it is what you make out of it, I guess.
So I am in the MD program, and so different from Raven, it's only 4 years, and it's split usually to preclinical to clinical years. So preclinical years, those first 2 years, you're in lecture, you're doing like anatomy, and you're just kind of hitting the hard sciences and just learning different organ systems. And then in the last 2 years, you are in the hospital doing different rotations for different specialties, and just kind of figuring out which specialty you want to just match in for residency, what you want to do, and just kind of getting a taste of everything in medicine as much as you can absorb. In terms of applying, I think it's important to just have a good kind of foundation in sciences. It's not obviously essential, because I know a lot of people who majored in completely different things than just like bio, but I think it's good to have a good or solid background. But yeah, I think it's super just, I think you have to just be a good team player most of the time and kind of go with the flow is what I've gathered. But I also haven't started rotations yet, so I think I'll figure that out as I go along.
Nursing has about a gazillion levels, as Harrison said. So if you're interested in nursing, you can be an ADN, where you can just go through like a small program, or an LPN and do their own test, or you can become an RN, which is where you pass the NCLEX, which is our certifying board. So anyone who's an RN has passed this NCLEX exam, and then you can be an RN without getting your BSN. So you can be an RN, you can be a nurse in the hospital without getting your bachelor's in nursing. But most hospitals in the city now, and most cities, want you to have your BSN. And with the BSN programs, you could do a traditional BSN nursing program in school in your like first round of college, or you can do what I did, and I got a degree in something else, and then I went back for my accelerated nursing. So it only took me 4 semesters instead of more with all my prerequisites. But I had to have basic chemistry, anatomy, physiology, things like that. I did not have to have a research course. Some of them do. Just be careful, because I thought I was going to apply to one of these places, and I couldn't because I didn't take this research course. And then basic pathophysiology and pharmacology you'll probably need to have before you apply, and then you'll take it probably again in your program, depending on where you go. And now, so then I got my BSN, and now I'm in an MSN. Thank you, Harrison, an MSN program. So this is like whole alphabet soup. I'm sure a lot of people don't understand this, and it took me a while, and I am a nurse, but now I'm in the Master's of Science of Nursing program. And so at this level, once I graduate in December, I can be an FNP, a family nurse practitioner, which is a type of APRN, Advanced Practice Registered Nurse. So I'm a registered nurse, but I've taken 4 extra semesters, which I'm in now, and done clinicals. And so I can be advanced practice. And so that means that I will wear a white coat, and I will be able to communicate and work at, depending on the state, depending on the laws, kind of ish the same level as PAs or doctors. So I would work under a doctor like a PA does. So it's similar to a PA, but kind of, but not really. And there's like a lot of choices between it. It's really confusing. But so then I'll be an FNP with a master's degree in December. And you can also go back and get your doctorate in nursing, which is a DNP, which would still be an FNP, still be that. It's just a higher level course. So then I would technically be like a doctor, but I wouldn't be a medical doctor or a doctor of osteopathy. I'd be like a PhD doctor. It's like a different type of doctorate, but you can get your doctorate in nursing. And they're trying to tell us by 2025 that they want all of the FNPs or all of the APRNs to be DNPs, to all have our doctorates, but that's not going well. So there's a gazillion different things you can do with nursing. You can work in a hospital, out of a hospital. You can write test questions for people. You can be a nursing legal counsel and review people's charts in court cases and make a ton of money. You can go any direction with it. Yeah. So right now, for applying to Emory, I did not need I don't think I needed a letter of recommendation. I don't think I needed a cover letter. I don't think I needed references or anything. I don't think I needed to write any essays. It was pretty easy to get in based on that. I don't even know if I needed to have the GRE. If my GPA was high enough, I didn't even need to take that. So make sure you check the listing because it was a good program.
First of all, I'm learning so much from all of you. It would be awesome. It would have been awesome to be an undergrad and have had this panel myself. So I'll go in order, kind of like undergrad up until now, and kind of give an overview of the curriculum. So for DPT school, most schools have the same prereqs. You do kind of want to look at specific programs because there are some slight differences. Kind of like Harrison said, sometimes they're like pretty kind of specific courses that you have to take for a specific program. And if you don't take that prereq, you can't apply. So that's why I definitely recommend looking into different programs you're considering before the fact, maybe like a year or two before applying. Otherwise, in terms of hours, I'm really surprised that this is the case, but the requirements vary, like small number of hours, like maybe like 50 to like 100 in most programs. But the more hours you have and the more settings you've worked in, the stronger your application. So like that's a pretty good thing to keep in mind. And then and that could be volunteering or working. It's either way. And let's see what else. Yeah, that's it for applying pretty much. And you don't have to major in anything specifically. Many of my classmates did do things like exercise science, biology, chemistry, athletic training, stuff like that. And they have a pretty good foundation of the things that are key to PT. But we have plenty of classmates that have different backgrounds. There's someone that was in art history. There's someone who was in marine biology, someone who had been working as in business, and he's in his 40s, and he's in our class as well. So plenty of different backgrounds. Many people, this is like their second profession. I think some of you have voiced that as well. So yeah, definitely great to have a diverse kind of class. So study what you want. You can do PT with your perspective. And then in terms of the curriculum, it's 3 years. First few semesters are kind of like Lena said, for the MD program, it's kind of similar in PT where it's all the kind of hard sciences. So all the foundation of anatomy, physiology, neuroscience, kinesiology, biomechanics, all the stuff, all the good stuff for PT. And once we get done with that, that's 2 semesters. It's a lot of like every program is a little different. So I will say I really like Emory's curriculum and the order in which things are done. That's part of why I came here. So I would look at the different programs and the order in which things are done. At the end, you'll get the same comprehensive overview of what they want you to know before you graduate to take the boards exam. But yeah, the order is a little different. So basically 2 semesters of the hard sciences, and then the next 3 semesters are going to be kind of these complexes where you learn about a certain like setting. So right now, for example, I'm in my 3rd semester, my first year, and it's the general medical complex. So everything having to do with like the respiratory rehab, cardiac rehab. We learn a little bit about neuro and a lot of other medical types of diseases, and kind of like what we really need to know to be good practitioners and work with alongside all the people we work in more inpatient type settings, more involved patients with more complex diagnoses. And it's also relevant for outpatient because many of our patients, we might be seeing them for something musculoskeletal, but they'll have all sorts of other things going on. Then the next semester is everything having to do with the musculoskeletal. That's many people's favorite semester, but many people end up kind of converting, they say, to like another kind of PT. The third semester of these complexes is neuro. So everything neuro, spinal cord injuries, stroke, Parkinson's, like developmental or degenerative neurological diseases. And then after that, we have clinicals. Each one is, oh, sorry, before I say that, each of those complexes ends with a short-term 2-week clinical where you go to a site, you have a clinical instructor, and you get to practice a bit, kind of what you've learned so far. And then it's a little introduction to clinicals. And then after that, once you're done with all of that, you do 10-week clinicals. So long-terms they're called, and you do them in 3 different settings. And you're encouraged to do settings that aren't necessarily the ones that you see yourself ending up in, just to see the different settings. And some can be in Georgia, some can be outside of Georgia. And then the last 2 semesters are electives. Emory has some pretty cool electives. You can dive deeper into certain parts of PT. You can get certain certifications like dry needling. It's something that's pretty unique about Emory's program. They offer that, which would cost a lot to take afterwards. So it's cool that they have that. And there are some service trips you can do at the end of certain electives, which is really cool. And that's pretty much it for DPT. And there are, I think, Robin has, if that's pronounced correctly, I apologize if I didn't, has mentioned kind of like a dual degree. It's the same with DPT. You can do plenty of different dual degrees, PhD, DPT. You can get your MBA, DPT, stuff like that. You just change like the order in which you do things. But yeah, and then you can specialize if you want. So you can do a residency and specialize in things like ortho or geriatric, stuff like that.
Cool. Thank you, everyone. So this will be my last question, and then we can open the floor and then wrap it up and be done before 8, well before 8. So my last question is, so, you're about to graduate, which for Raven, good luck, that'll be, the world will hopefully not be underwater by that point. But what do you do? Right. So first of all, what do you plan on doing if you know? If not, that's fine. But I think one of the very interesting things that I did not know when I decided to come to med school is the path after graduation looks very different for a lot of us. And so what does your path look like to become fully certified? And then, are there any options, let's stick with you, that you yourself are considering that would require extra training or anything like that? Obviously, there are millions of options for everyone on top of their degrees because medical training never ends. So we do not need to go over all of them, but if there is something that you are thinking you're going to pursue, you can say that. And if not, I think that's also very valuable to know when you are allowed to be an independent human and start your own practice, go, do your own thing. And when, like, in your schooling, that actually becomes applicable, because I know that's different for all of us. So we'll go in the same order. Does that make sense? Do I need to clarify that at all? All right, Catherine.
Can you type it in the chat, like a succinct version of, okay, thank you.
Yeah. Yeah, so I'm going to graduate in December. I didn't mention it, but we also have like a didactic year and a half in the classroom, then a year of clinicals. We do month-long rotations. I'm in emergency right now. After graduation, if you're a PA, you have to pass a national licensing exam, and then you also have to get certified by the state board wherever you're going to work. That, rumor has it, can take months. Most people try to take the board exam pretty soon after they graduate to get that part done with, and then to start on the paperwork. The laws for PAs vary a lot state by state. In most states, you need a supervising physician. What that relationship looks like varies a lot, also just by employer as well as by state. In some places it means you like literally work side by side with a physician. In some places it means you can basically own and run your own practice, but you have a doc who has some level of review, maybe does some chart reviews once a week, maybe is like practicing alongside you, but you're seeing patients separately and you can kind of consult. So that, and there is like a movement towards optimal team practice, which means really letting PAs practice the full scope of what they can do, while recognizing that we basically get a super good training in like, you know, primary care family medicine, and anything more specialized is its own thing. There are residencies for PAs. It's something I've thought about. I'm a little bit up in the air, but I'm kind of interested in emergency. I think as a PA in the emergency room, you can have a really good scope, but also you have to be able to kind of prove your chops. And it makes sense that if you do an extra year of training and do all these procedures and then can walk in and be like, I've done X number of these procedures, that's going to get you to practice within your scope a lot quicker than if you're like, I'm a new graduate and I'm here to learn. But you know, it's different obviously from like being a doc, going to residency, having like a specialty like that. What else? Yeah, I don't know, PAs work in all kinds of fields. I think it really varies a lot by what you want to do. If you're a surgical PA, you know, you're not going to be running the surgery. And I think that's a pretty close partnership with a surgeon, which is different than like family medicine PAs who may like run their own clinic and see patients and have a lot of autonomy versus like hospital-based PAs. And to some extent, NPs apply to some of this, not totally, the laws vary, but work in a lot more of a team-based approach. So yeah, and I think some of my classmates know what they want to do and some have no idea, and I'm glad we get clinical year to explore. But I think going in, at least with the sense of like what you're doing in medicine, like I know wherever I wind up, I want to work with underserved communities and be someone who expands access to care, whatever that is going to look like for me. So that's kind of my goal.
And no residency required, but you said average, would it be fair to say an average length of a residency is around the 1 year?
Yeah, so residencies are usually like 1 to 1.5 years. It's still like a pretty small minority of PAs that go on to residencies. If I had to guess, probably 5 or 10%. At some places that basically your first job, if they're good, will take on training you, kind of recognizing you're at a good spot when you graduate, but whatever spot you're working in, you need to be trained into that. So the residency can also just essentially be your first job. And PA residencies are paid. So that's nice. But yeah, correct. They're not required, and there's still a minority of PAs who will go on to do that.
Okay, so I probably should have said this when exactly you would do your PhD. If you're in a PhD only program, when you get in, you start classes in research parallel. But if you're in an MD PhD program, most programs usually let you, after your preclinical book learning, they pull you out and then you start your PhD. Some programs, like Emory's transitioned to, they let you do your 3rd year of clinic, and then they put you into the PhD because they think that you have an idea of what you want to do and you can align your research to best suit that. So after you're in school for 7 to 10 years, if you have any motivation left, you can do a bunch of things. So most people go into a traditional residency. I won't talk too much about those because we have a few MD students on the call and they'll definitely talk about that. But there are a few things that MD PhDs also do. Some people who have came and talked to us and who also teach, they opted out of doing residency. They have the clinical background to, or I guess the clinical experience from medical school and the physician, I guess, approach to certain problems. And they also have the basic science approach, so they use that more in a research environment. They run their own labs. They don't see patients, but they can do what a lot of people call translational research, which is like research that is not available, like you're not in the clinic now 100% or FDA approved, but you're not just trying to figure out the basics of new things, like you're at a middle ground. Other people have gone into finance and consulting careers because they can say, well, I know what we would do in the clinic and I would know the research to get something to the clinic. So they find that and they end up in business. And it doesn't daunt them because it's kind of shaves down training. You can also do that after residency, plus or minus residency. But a lot of people will say that if the more clinical training you get, the better for any alternative career because it is experience and it will help inform how you use your degree. Most people go into residency, which is training for your specialty. There are a few special residency tracks called PSTPs, which are physician scientist training programs. And those are for medical doctors who want a residency, but they also want to maintain their research training because research training and clinical training are very different. So what you do is how they're talking about some rotations and how Catherine spoke to, okay, you can rotate in the emergency department and different stuff like that. When you are in your, let's just say you do internal medicine or anesthesia, you will have specific rotations in the operating room, in the ICU, but then they'll pull you out for a certain amount of time and you can do a research rotation and you'll do research on anything relevant to that specific field of medicine. If you're getting a PhD by itself or an MD PhD, most people do a postdoc, which is exactly what it sounds like, postdoctorate degree. You work in a lab. You are above the level of a graduate student, so you're not necessarily being told what to do, but even grad students aren't necessarily being told what to do, but you are right before the level that you can start your own lab. You have your own autonomy per se. You usually have your own funding to support your own salary, and you design experiments in alignment with what you want your career to look like. And some people even opt to go into industry. And I know quite a few people, they've gone to work on different companies. So I have friends who they got a PhD in synthetic chemistry and they're interested in cosmetics. So they go and work at L'Oreal and Revlon because they are outside of academia and they have a job where they do science, but it's not more discovery-based science. It's more so like, this is how we need to check our products that we're producing and stuff like that. So you can do pretty much anything that you want. You can go into retirement. That's what I'm planning to do after graduation. I'll let you all know how that goes in 2025 or 6. But yeah, you can do a ton of things.
Awesome. For just time, we can, Nathaniel, is there any specific EMT angle be helpful?
Mostly just knowing to like, yeah, just mostly knowing like you have to take your national exam. There's different state licensures requirements. You have to do continuing education over the years to be able to keep your license. And then usually they're going to, once you get into a job, they're going to do additional training on you to make sure that you know what you're doing before you're actually allowed to like be out there on your own, working with your partner. And then that's really it. Most people, a lot of people end up moving up a level depending on where they started from. And you can do a variety of jobs, I guess. You can work like 911 side, you could do events, you can be an ER tech if you're like an AEMT or a paramedic. But yeah, that's mostly it.
Okay. So for graduation, after you get your MD degree, you have to go to residency. So you have to match into a program somewhere. And it's kind of divided between 2 paths. Generally, it's like surgery or internal medicine. And so there are a few specialties that you directly match into. So for example, I'm interested in dermatology. So you would match into a transitional year, and then you would do 3 years residency for dermatology. But if you were doing internal medicine, you would just match into internal medicine, and that's a 3-year residency. And from there, you can continue on and do a fellowship and subspecialize in something. So that's kind of how like endocrinologists, nephrologists become nephrologists and whatever. But yeah, I think it's typically, that's all. I only really know like the internal medicine path. The surgery path is like way more, it's longer and more like convoluted, but I think general surgery is like 7-year residency. And then from there, a lot of people subspecialize as well. But I think those are just like the general paths for 2 things. It's basically surgery or internal medicine. And then from there, you can subspecialize, but it branches out a lot.
Okay, so for there's nursing and then there's NP. For nursing, I forgot to say that they just throw you into clinical. I was in clinical. I was in the hospital 7 weeks after I started. We didn't know anything, and we learned like this is a drain, this is how you do a bed bath, and they just like threw us in, which is really cool. And we learned. I loved it because we got to learn like, oh, I saw this in clinical last week, and then we could ask about it in class and go through it slowly. So it was good. For RN residencies, for BSN residencies, most hospitals in the city want you to do a residency after you are at a nursing school. So you're a nurse resident, and like Grady's is 2 years, I think. Emory's is 2 years. Piedmont is 1, Northside is 1. And I'm in a Piedmont one right now, and it's like 3 or 4 months of training. Depending, it'll be like 10 weeks to 16 weeks of training following a preceptor, and then you're on your own for a year or two, but you have a few extra trainings and things like that. And I think pretty much everyone wants you to be in the residency program. If you want a full-time job in a city, you have to be in a nurse residency program first, usually on nights, not always, depends on what you get. But if you're in a smaller town, I don't think they require residency for you. And then for NPs, it takes several months after graduation to become certified and licensed and everything in your state. And then at that point, I think it's like, I don't know, April or May, people are aiming for. So after a December graduation. So there's time to be a travel nurse. There's time to go do whatever you want before you can start making money. But some NP residency programs are popping up in the last 5 years. They are also like the PA, they're newer, they're not required. I think every profession is doing this. They're like getting some sort of residency program, but ours aren't required by any means. And then at that point, I can work as an FNP, I can work in the ER, but there's different ones. There's like adult gero NP, which would deal with a lot of older people with like polypharmacy or veterans or hospice or things like that. And then there's peds, there's emergency, there's women's health, and then there's midwifery. There's a whole bunch out there. So then you would just go into your specialty then. And then like Catherine said, if you can either like work side by side with the doctor or see your own patients, or if you can like run the clinic in a small town and a doctor will swing by once a week and like give you a thumbs up. So it's several layers, and then it depends on the state too.
So with physical therapy, where do I start? You can practice right after you graduate as long as you're taking your board exam and passed. For the most part, each state has a different license. So you'd have to take the license for the board exam for the state you want to practice in. And then if you ever want to transfer your license, like say you're living in one state, but you don't want to start practicing in another because you want to move there, you just usually, depending on the state, you have to take what's called the jurisprudence exam, I believe. So you just have to learn the laws of that state, because many things differ from state to state for PT. I know they're trying to work towards having like kind of states merge, and like, so if you have a license at one state, it applies to several. But we're still, I think, in the early stages of that. I don't know how long that'll take. And then otherwise, you can really go in any direction in terms of where you want to work, like what setting. I will say, kind of Harrison mentioned like private practice and all that. I'd say you can open a private practice, but it's gonna be very difficult early on because you want to gain a lot of experience and just kind of, like have contacts, and it's really important to have a network if you want to have a private practice, whether insurance-based or cash-based. Yeah, and then you can do travel PT as well. And usually, I don't know too much about it, but companies can kind of help you get those certifications. Well, sorry, the license in the state you're going to go to pretty quickly and easier than if you were to do it on your own. And also just finding opportunities, because opportunities open up in many places, sometimes because someone's on leave, or they need someone short term while they find someone, full time. Yeah, and then also what I was going to say is you can do full-time at a certain location. You can do part-time. You can also do per diem. What a lot of PTs do is they'll work part-time or full-time, say like in an outpatient setting sometimes, and they'll do per diem at a hospital, like on weekends or holidays. So it's just when you're needed and when you're available. And usually the pay rate is higher, but there's no benefits. So that's an option. And in terms of specializing, residencies, I believe, are also a year. And you can specialize in many different things. And that just kind of strengthens your I mean, it improves patient outcomes, and it also just strengthens your I guess your CV when you apply to different places. And the path looks pretty different depending on what path you want to go. And I know for sports, you kind of want to start early in terms of having certifications, like having contacts, getting a lot of experience, like really making connections, stuff like that. It's very competitive out there with sports, especially professional, because it's like very hot, very low demand and high supply of PTs that want to do that. Otherwise, I think there's always a need for PT everywhere in the world. I also heard, this is kind of an aside, but if you want to practice outside of the US, it's actually supposedly easier to get licensed in the US and then practice elsewhere rather than vice versa, because here it's a doctorate, whereas I think in most places it's not. So the transition is a little easier. Yeah. And yeah, there's probably more, but I can't think of anything right now. Yeah.
Yes, and we don't expect anyone to fully encompass the breadth of their field. So there's always things we're forgetting. And if I typed anything incorrectly about your field in my little summary, just correct it and retype it yourself. Okay, so we have a few questions now that we'll zip through. And if I don't get to yours, then you can unmute yourself and say it, because I only have 3 right now, so we can do this.
Could I add one more thing?
Yeah.
I was just going to say with physical therapy, just got to remember the second part of your question was like, what do you want to do? So I know that I would like to teach at the graduate level and maybe also like earlier, but I know that many of our professors are either have a PhD, do research and teach, you know, what they're specialized in, or kind of work in a clinical environment and teach. So those are both options, and I definitely would prefer the second. But yeah.
Yeah, I didn't include the PhD option in the list, but it's there. Okay, so the first one, I believe this one will go to Catherine. What is the law in Georgia for how much autonomy a PA has? In a few words.
Yeah. So Georgia is a state where you need a supervising physician. That means that to be able to practice at whatever place you're employed, you need someone who's on your license. So who that is changes based on where you're working. You don't have to like go out and find them. Typically, if you're getting hired, whatever the setting is, that will already be set up. But yeah, like I said, that doesn't necessarily mean like you go see the patient and then the physician goes and sees the patient. What I've mostly seen is the PAs like practice in the hospital, see their patients, and then the physician may see the patient on their own and sign the chart, or may just chat with a PA, or may just read the charts later. I think there's only a couple of states where PAs don't need a supervising physician. There's been a big move in the last year to change it. And I'm not sure if I'm going to practice in Georgia, but I wouldn't say it's something that affects my choice of where I'd want to practice, because I also want to be part of a team. So it doesn't honestly feel that different to me. I wouldn't be taking on patients beyond the scope of my ability. You know what I mean? Like I wouldn't take anything on beyond my scope or try to have a doctor level knowledge that I don't have. So it's kind of more like you're part of a team, and for your license, you have a physician as part of that. I don't know if that was clear at all, but also I might be a little hazy on it. But functionally, it kind of looks like you're in the hospital doing your thing, working with your colleagues.
I want to add to that really quick, just to give an example. Right now in Georgia, it's the most restricted state for NPs in the nation. And right now in Georgia, PAs and NPs cannot prescribe Schedule II medications to patients, like opioids and things like that. We cannot prescribe them on our own. A doctor has to do it, but it's always changing. And like my program director testified in front of the Georgia legislature today about allowing PAs and NPs to do that in an emergency for a prescription not to exceed 5 days. So we're like inching forward. We're getting there.
Doctors have clearly been doing a wonderful job at prescribing those drugs, so makes sense why we only have access. Anyway, yes, I will just tack on to Catherine's point that I think every field is a team player field, which I don't really think anyone tells you before you apply, because like in your own mind, you're just doing your job like out in the world and like gunslinging, and nothing is like that. You're always working in a team. So I think that is something communal. The next question goes to Raven. It is about being an international student. And the question comes from Caitlin. If I misphrase this, let me know. So she was saying, as a med student, they require research and shadowing, but as an international student, it's hard to get clearance to do these things. And she wants to know how you navigated that.
So I'll be quick, but this was a challenge for me too, so you are not alone. I'm from the Bahamas, and a lot of shadowing and research experiences, especially like paid research ones, that my friends were doing, or when you go to your undergrad, like pre-med, pre-PhD office, they're going to give you a long list of things. And the first requirement for consideration is going to be US citizenship or permanent residency. And then you're going to feel a little broken. It's normal. I felt there and I'm here now. What I would first start off with doing is trying to see if you can start as an undergraduate research volunteer. There should be an undergraduate department of research, or you can do what I did and just Google research at your school and start walking into random labs. Both of those things work. People will usually not turn away free help. And even if you tell them that you don't know how to do anything, they'll teach you. So that's something that they don't have to do. On the research side. For shadowing experiences, it is a bit more difficult because there are a lot of background checks and things that you have to go through. And when they send out your background check and nothing comes back, or when they try to tag a social security number that you may or may not have to that background check and nothing comes back, that could be an issue. But what I would recommend is trying to get shadowing experiences with smaller private practices, because those people you can just send an email to, and you can reach out to them one-on-one, and you can let them know from the front end, hey, I'm an international student. I'm willing to provide whatever documentation that you need, but a lot of the formal shadowing experiences aren't an option for me, because that's something that I did. A lot of the larger hospitals, they had shadowing programs, but half of the required fields you couldn't fill out. And that also is a challenge. But you can definitely get my email. I can tell you a little bit more how I moved through that process if you'd like.
Wonderful. Thank you for sharing that. And then the last question, so if you have questions, send them soon. It's sort of a specific question, which I don't know if we're going to be able to answer, but we can try. I think it sort of would fall to Catherine and potentially someone in the MD program. So Carly's interested in orthopedics and sports medicine. She's been thinking about MD, and I guess depending on what side of sports medicine, also Stefano. She's been thinking about an MD, but has recently become aware of PA school. What would a PA in this environment look like, and what would their responsibilities look like? So Catherine, I don't know if you, I know it's very specific and it's not necessarily your area of interest, but.
Yeah, I can try. So one route to PA is being an athletic trainer. There's a couple ATs in my class, and a lot of them want to go on to ortho because that's kind of the thing that's best aligned. And I think this is kind of implied, but just to be clear, so yeah, PA school, you get trained in family medicine, essentially. You get trained to give really good primary care. And then from there, you can do anything. It's not like NP where you kind of track towards family or peds or, women's health or whatever. So you can do anything, and you can even switch, like you could work in ortho for 5 years and then change your mind. It's probably easier to switch to a related specialty than to just go from like dermatology to critical care or something. But that is something that draws a lot of people to PA, is if you feel a need to switch what you do every 5 years, you can do that. As far as what ortho PAs do, I think you'd probably work alongside an orthopedic doctor. You could work in an operating theater doing like surgery. You could be seeing patients in outpatient clinic. You could be a consultant and be consulting on people getting admitted to the hospital. All of those are kind of within the PA role. So yeah, I think, again, you'd be working like with a doc who's an orthopedist, but would probably get to do a lot of fun stuff. I've been able to do a lot of splinting, interpreting x-rays, looking at fractures, and like at least doing the emergency side of that care, and then, giving them referrals to follow up with ortho. So it is one of the popular things for PAs to do, although I don't think it's my thing, but respect for that.
Yeah, and just to clarify what Catherine's saying is, I think PAs have sort of the easiest time switching paths. With any of these terminal degrees, you can end up doing anything you want to do. The question is how far back we roll back the tapes to do that. And I think MD is the worst for that. And it sounds like PA is the easiest. And I'm not quite sure where NP would fall within that. I assume better than MD, but
we're also easy. Yeah.
Okay. So that's just a consideration, which I did not know going into med school. Is there anything you wanted to tack onto that, Lauren?
I mean,
for NPs,
with nursing, it's easy to switch. Like with PA school, you just pick another doctor to work under. With FNP, I can work anywhere: ER, urgent care, primary clinic, underserved, all the things. I can't remember what else I would say, but yeah, it's easy. It's fine.
Cool. And you do have specific tracks you could do if you knew ahead of time, right? Like if you knew you were interested in midwifery, you could potentially go to school with that in mind, right? But that doesn't necessarily bind you. Is that a fair thing to say?
I think FNP would be the most broad, I guess. So if you're certified in midwifery, you can't practice in a family clinic. So FNP is the most broad, but I know people that are like, I hate children. I don't ever want to be near them. So they're in adult gero. And some people are like kids or nothing else. So they're in peds. So you can choose. It doesn't really matter. But FNP, with that one, you can go all sorts of directions.
Okay, cool. That's I get confused on that too, because I'm always with different NP students. I'm like, what are we?
I know. And another plug for nursing, it looks better on your resume if you've done like 10 different jobs, I guess. Loyalty to a job doesn't really apply in nursing. So more experience, the better in all different areas. That's great.
Oh, go ahead. Yeah, jump in.
I was just going to say that PT is kind of similar to nursing and PA in that way, that like it's very easy to switch settings. But I was also going to say, because I think it was spoken about a bit earlier by Catherine about PA, in terms of the question of autonomy. With PTs, I think it's very similar to like PA and nursing and maybe EMT. Maybe Nathaniel can speak to this, but basically I think all of these professions are really progressing in like kind of how much autonomy they have, like how advanced the degree can be, stuff like that. Because up until recently, physical therapy was a master's, and it's only just now that it's a doctorate, maybe like within a few years. So you'll still meet a lot of PTs that are that have a master's in PT and are actually going back to get their doctorate. But the goal is to have everyone have a doctorate. And then it varies by state, similar to what Catherine was saying in terms of how much autonomy you have. Because I think in some states there's more and more what's called direct access, which just means a patient can go straight to a PT clinic without a prescription, referral, or anything from an MD. But it's pretty limited, and it depends on where you are. And by limited, I just mean if you're going insurance-based, for insurance to cover for a certain thing, you have to have a prescription for it. And direct access, maybe it'll cover it depending on your insurance and depending on the state, up until a certain number of sessions, and maybe limiting certain treatments. But just like I was saying before, I think all of these professions are progressing towards being more autonomous. And it's always a team, but I think that it's cool how like each of us have unique kind of perspectives, and it's with more education we're able to kind of take on more autonomy in the care of a patient, if that makes sense.
Okay, thank you everyone. Last, this is a really weird question to end on, but since it was asked, we have to do it. It's a great question, but it's just like a very specific one. And I think it's super helpful. Is how long is the training for surgical PAs, and can they perform their own surgery? Catherine, do you want to speak? I can also speak to this.
Yeah, so the training would be however long your PA program is. So anywhere from 24 to 36 months probably. And no, you wouldn't be the surgeon. So most surgical PAs would be like the first assist. So, you know, you participate in the surgery quite a bit, but you're not the person who's like necessarily directing everything that's happening or being the primary operator, if that makes sense. But you're in there and you're cutting and sewing and helping and whatever else. So yeah.
Cool.
NPs can also do a lot of procedures. I feel like I have to keep plugging this. I'm sorry, everyone. NPs can also do a lot. And in the ER, a lot of the NPs get to do a lot of the stitching and like splinter removal and like eye removal. I've already learned how to do a lot of that in my clinicals at school, and it takes time, but it's not necessarily that hard compared to what the doctors are doing. So a lot of times the doctors won't do it and they'll just give it to the NPs or the PAs to do if you're interested.
Beautiful. Okay. Any last, we went over, which makes me sad, but any last burning desires, questions, comments, concerns? Going once. Going twice.
Here are our emails so they can kind of use this as a resource if desired.
Yeah, absolutely. Go ahead and Catherine is ahead of the game here. Yeah, so you can go, if you would like people to have your emails, you can go ahead and pop them in the chat, and then we can also disseminate those to our Georgia Tech friends. And before we go, anyone on the panel have any last burning things that they would like to say?
I have a piece of advice for everyone. No matter what our profession, all of us had to get a lot of patient contact hours to be in our fields. And I recommend getting a job as a PCT or a patient care technician in the hospital. You can be in the ER and see a lot and do a lot more, or you can be at the bedside upstairs and really you can see the ICU and you will see MDs and PAs and NPs working together, and you'll be able to choose, and you'll be a part of the team. You won't just be shadowing, and you'll be able to choose which one is best for you based on that, and get paid and get hours in the process. So I would recommend that if you're curious right now.
Beautiful. That is great advice. Okay. All right. Well, thank you so much for joining. Thank you to our panelists. We will have this recording available if anyone needs it. And have a wonderful rest of your evening.
Thank you,
Thank
Harrison.
you guys so much.
Nice to meet you all.
Bye. Great to see you all.
Great to meet you. Thanks, Harrison, for organizing.
Of course. It's great to see all of us in the same place. And nice to meet you, Stefano. Thanks for doing this on a somewhat short notice and only via email introduction. And hopefully we'll see you again in person. Yeah. Okay. Lovely. Well.
And I love EMTs. I work with a lot of them. You do great work. You don't get to talk much, but.
I love nurses. They're great too.
Right.
My mom's actually a CNA.
Okay, fair. It's a good job. It's good. So nice. Okay. Have a good night.
Good to see y'all.